Treatment. In deciding upon the proper course of treatment for any individual case of movable kidney, the surgeon must bear in mind the following facts. 1. In many cases, nephrotosis produces no symptoms. 2. In many instances, nephropexy, while it retains the kidney in place, which it does not always do, either fails to relieve or aggravates the neurotic or dyspeptic symptoms attributed to renal mobility. In view of these facts, we must hesitate to elect nephropexy, a treatment which, though surgically a success, may prove clinically a failure or worse than a failure. Mechanical treatment supporting the kidney by a suitable belt may always be experimentally employed in doubtful cases. But to have recourse to surgery is a grave matter, not because of the danger or discomfort connected with the operation, for the former is almost nil, the latter inconsiderable, but because in most instances the patient is distinctly neurotic, and while the influence of the operation per se may be beneficial, it may also be injurious. In short, the knife is no proper instrument for a faith cure. Its brilliant successes should not blind us to its failures. Yet where palliative measures fail and the symptoms are apparently dependent upon the renal mobility and require relief, there is no choice. An operation is then surely the lesser evil. So we may conclude that the treatment of subjective symptoms due to renal mobility is palliative. Surgical measures should be reserved for the treatment of kidneys showing definite pathological lesions and for those cases that do not respond to persistent, intelligent palliative treatment. Palliative treatment. The broad lines of palliative treatment are the following. 1, to remedy digestive and menstrual derangements. 2, to correct position and avoid overfatigue. 3, to improve the general vitality and combat neurasthenia by overfeeding, massage, hygiene, and tonics. And 4, to apply an abdominal supporter. Much emphasis is placed upon the kind of belt or corset employed to support the abdomen. Etta Bowles reviews the opinions of various writers upon this subject, even to that of Gertzberg, who, quote, administers a yeast ferment with the object of producing meteorism and thus sustaining the prolapsed kidney, end quote. This is an extreme example of the fallacious impression that a support must be worn solely for the purposes of retaining a kidney in place, and that, this accomplished, the cure is assured. Nothing could be further from the truth. As a matter of fact, it is the patient's general condition that should be attacked primarily, the local condition only secondarily. Many a case of, quote, movable kidney, end quote, is cured by hygiene, diet, and exercise, while the kidney remains as loose as ever. Moreover, in applying a belt or a corset, the effort must be made to support all the abdominal viscera, not the kidney only. It is not conceivable that any form of pad should hold the kidney in place, and therefore it is wiser to dispense entirely with pads and to support the abdominal contents en masse. For this purpose, the modern straight front corset may be employed. Some women find that this, if applied in the recumbent position, acts as an admirable supporter. The backbone of the non-operative prevention and cure of the symptoms of nephrotosis is a course of orthopedic training in proper position. The patient must learn to stand and walk, touching the clouds with the crown, chest out, and everything else, chin, abdomen, lips, toes, in, must be the rule. Such an attitude makes room for the solid viscera under the diaphragm and relieves many patients. Surgical treatment. Nephropexy, nephrorrhaphy, is the operation of fixing the prolapsed kidney against the abdominal wall. Results of nephropexy. The earlier nephropexies were so uniformly followed by relapse that many physicians opposed the operation on the ground that a permanent cure was never accomplished by operation. But recent statistics tell an entirely different story. Morris has performed 98 nephropexies with 1 death. Cardiac thrombosis in a stout female whose kidney was incised and explored before being fixed, and only, quote, a few, end quote, relapses after operations performed according to, quote, a plan different from the present methods, end quote. Edibles reports 193 cases, 68 bilateral, with 3 deaths and 2 known relapses. All of my own cases have been successful. But nephropexy may be regarded from another point of view. In a very considerable proportion of cases, the patients have complained of more pain after the operation than before. This may be due to one of several factors. Perhaps the pain did not commence in the kidney and therefore was not relieved by operation, but was rather intensified by the shock and disappointment. Or perhaps it was due to adhesions or kinks of the ureter, which were not relieved by the surgeon. Or perhaps the kidney was replaced high up in the loin in a niche from which it had descended because there was not sufficient room for it. However this may be, I have had only one patient complain of a recurrence of pain. Nephropexy was performed upon her as a lesser evil than exploratory abdominal section with which she was threatened by another surgeon. Her various neurotic symptoms, which had existed for years, immediately disappeared. 5 years later, they returned, and she underwent at the hands of various surgeons the extraction of several teeth, drainage of the antrum of Highmore, excision of the inferior dental nerve, nephrectomy, the kidney was found firmly adherent, vesicovaginal fistulization, an infinite variety of other treatments, all to no avail. It has been interesting to find 2 reports of her cure, the one by a dentist, the other by a physician who inflated her colon with carbonic acid gas. Finally, exploratory laparotomy was performed a year ago. A normal appendix was removed, and she has remained better ever since, though far from well. She has been poisoned by a rectal injection of boric acid, but survived.